Now I am Dr. Prasanna Yadav, Department of Medicine, Index Medical College. We are discussing on infectious diseases. The first topic is cholera. Cholera is an infectious disease which is caused by a bacteria. Cholera is a Greek word which means the gutter of roof. It is caused by a bacteria that is Vibrio cholera, which is discovered in 1883 by Robert Koch during diarrhea outbreak in Egypt. Vibrio cholera has two major biotypes, classical and Altor, which was first isolated in Egypt in 1905. Currently, Altor is a predominant cholera pathogen. The organism is a comma-shaped gram-negative aerobic bacillus whose size varies from 0.3 mm in length by 0.5 into 0.8 mm in diameter. Its antigenic structure consists of a flagellar H antigen and somatic O antigen. It is the differentiation of the latter that allows for separation in pathogenic and non-pathogenic strains. Now this is the picture which is showing the bacteria that is Vibrio cholera. As far as epidemiology is concerned, since 1817 there have been 7 cholera pandemics. The first 6 occurred from 1817 to between 1817 to 1923 and were caused by Vibrio cholera, the classical biotype. The pandemic originates in Asia and subsequently spreads to the other continents. The 7th pandemic begins in Indonesia in 1961 and affected other countries and continents that the previous 6 pandemic it is caused by Vibrio cholera Altor type. In October 1992, an epidemic of cholera emerged from Madras, India, as a result of a new serotype that is 0139. This Bengal strain has now spread throughout the Bangladesh, India and neighboring countries in Asia. Some experts regards this as an 8th pandemic. Reported cases. The number of cholera patients worldwide is uncertain causes most cases go unreported. The number of cases is increased during epidemics and is infected by environmental factor. In 1994, 94 countries reported about 385,000 cases of cholera to WHO, and the number reported in 1998 was 121,000. 89% of these cases were reported in Africa. During the 6th pandemic, the case fatality rate were very high, 50 to 70%. After 1960s, dramatic reduction occurred due to replacement of the classical type with Altor serotype and the advancement in the understanding and treatment of the disease. Now, as far as pathogenesis is concerned, cholera is a toxin-mediated disease. That is toxin-mediated disease. These toxins acts on the small intestine. To reach to the small intestine, the organism has to overcome the defense mechanism of the GIT, that is acid media in the stomach. It secretes certain mucinase which helps it to move rapidly through the mucus. They also depend on the large inoculum size so that bypass the gastric acidity that got adherent to the epithelial surface, probably by certain factors. Then they produce their enterotoxin, which consists of two types, light one and heavy one. Light one is L toxin and heavy one is H toxin. The L toxin combines with the substance known as gangliosides. The product may make the organism binds to the cell wall. This binding is irreversible. The H toxin acts by activating adenyl cyclase. This activation leads to the rise in the level of so-called 3,5-adenosine monophosphate, that is cyclic AMP. This substance inhibits the absorptive sodium transport and activates the excretory chloride in the intestinal cell and accumulation of NaCl in the intestinal lumen. This high osmolality is balanced by water secretion. The result is in watery diarrhea. The large volume of fluid produced in the upper intestine, however, overwhelms the absorptive capacity of the lower bowel, which results in severe diarrhea. The enterotoxin acts locally and does not invade the intestinal wall. As a result, few WBC, not RBC, is found in the stool. Fluid loss originates in the duodenum and upper jejunum. The ileum is less affected. The colon usually is in the state of absorption because it is relatively insensitive to the toxin. Now, as far as agent factor is concerned, resistance, Vibrio cholera are killed within 30 minutes at 56 degree temperature or few seconds by boiling. Remain in ice for 3 to 5 weeks or longer. Drying and sunshine will kill them in few hours. Disinfectants kill them also. Now, reservoir of infection. Human is the only known reservoir of cholera infection. The ratio of severe cases to mild one is shown to be 1:5 for classical type and 1:25 for LTOP. Transmission. Cholera is transmitted by fecal-oral route through contaminated water and food. Person-to-person infection is not so common. The infectious dose of bacteria required to cause clinical disease varies with the source. If ingested with water, the dose is in the order of 10⁻³ to 10⁻⁶ organisms. When ingested with food, fewer organisms are required to produce the disease, that is 10⁻² to 10⁻⁴. Vibrio cholera is a
आप जो शुरू से करते हो ट्रांसमिशन
पहले पुराने वाले से
यहीं से ट्रांसमिशन से
हाँ Vibrio cholera is a saltwater organism and it is primarily habitat in the marine ecosystem. Cholera has two main reservoirs, main and water. Animals do not play a role in transmission of the disease. Vibrio cholera is unable to survive in the acid medium. Therefore, any condition that reduces the gastric pH increases the risk of acquisition. Host susceptibility. The use of antacids, histamine receptor blocker, proton pump inhibitors increases the risk of cholera infection and predisposes patient to more severe disease as a result of reduced gastric acidity. The same applies to the patient with chronic gastritis secondary to the H. pylori infection or those who have had a gastrectomy. At-risk group. All ages but children and elderly are more severely affected. Subjects with O blood group, cause is unknown. Subject with reduced gastric acid. Social class and economic class. Now, as far as clinical picture is concerned, incubation period is 24 to 48 hours. Symptoms begins with sudden onset of watery diarrhea, which may be followed by vomiting. Fever is typically absent. The diarrhea has a fishy odor in the beginning, but becomes less smelly and like rice water in few hours. In severe cases, stool volume exceeds 250 ml per kg, leading to severe dehydration, shock, and death if untreated. Cholera in children. Breastfeed infants are protected. Symptoms with severe and fever is frequent. Shock, drowsiness, and coma are common. Hypoglycemia is a recognized complication which may lead to convulsion. Rotavirus infection may give similar picture. Now, as far as complication is concerned, if dehydration is not corrected adequately and promptly, it can lead to hypovolemic shock, acute renal shutdown, and death. Electrolyte imbalance, very common. Hypoglycemia in children. Complication of therapy like overhydration and side effects of drug therapy. Now, what about the lab diagnosis? Is organism can be seen in stool by direct microscopy after gram stain and dark field examination. Examination is used to demonstrate mortality. Cholera can be cultured on specific alkaline media like triple sugar agar or TCBS agar. Serologic tests are available to define strain, but this is needed only during the epidemics to trace the source of the infection. Other lab findings are dehydration that leads to high blood urea, high serum creatinine level, hematocrit, and WBC will also be high due to hemoconcentration. Dehydration and bicarbonates loss in stool leads to metabolic acidosis and with wide anion gap. Total body potassium is depleted, but serum level may be normal due to acidosis. Now, as far as treatment is concerned, the primary goal of therapy is to replenish fluid losses caused by the diarrhea and vomiting. Fluid therapy is accomplished in two phases: rehydration and maintenance. Rehydration should be completed in 4 hours, and maintenance fluid will replace ongoing losses and provide daily requirement. Now, WHO guideline says step 1, assess the degree of dehydration. Step 2, rehydrate the patient and monitor signs frequently. Step 3, maintain the hydration. Step 4, administer oral antibiotics to patient with severe dehydration. Step 5, feed the patient. Now, severe dehydration. Administer IV fluids immediately. Monitor the patient very frequently. Radial pulse and blood pressure. Reassess the patient after 3 hours if still having signs. Repeat the IV fluids. Fluid therapy. Ringer lactate solution is preferred over normal saline because it corrects the associated metabolic acidosis. IV fluid should be restricted to patient who purge more than 10 ml per kg per hour for severe dehydration. The oral route is preferred for maintenance, and the use of ORS at a rate of 500 to 1000 ml per hour is recommended. Drug therapy. The goals of drug therapy are to eradicate the infection, reduces morbidity, and prevent complications. The drug used for adult include tetracycline, doxycycline, cotrimoxazole, and ciprofloxacin. For children, erythromycin, cotrimoxazole, and furazolidone are the drug of choice. Drug therapy reduces volume of stool and shortens period of hospitalization. It is the only needed for few days, 3 to 5 days. Drug resistance has been described in some areas, and the choice of antibiotics should be guided by these resistance pattern. Antibiotics should be started when cholera is suspected without waiting for lab confirmation. Now, prevention. Education on hygienic practices, provision of safe uncontaminated water to the population, antibiotic prophylaxis to household contacts, vaccination against cholera. Cholera vaccines. The old killed injectable vaccine is obsolete now because of it is not effective. Two new oral vaccines become available in 1997, a killed and a live attenuated type. Both provides a local immune response in the gut and blood immune response. Cholera vaccination is no more required for intestinal travelers because risk is small. Step of epidemic control. Isolation and barrier nursing is indicated. Verification of the diagnosis. Notification of the case to WHO and MOH. Early case finding and tracing source of infection. Establishment of treatment centers. Thank you.